I don't know. Okay.
I have mentioned those. No box. Yeah. So this is where I go to these old.
Yeah, and this was it's under lab documents under the lab.
All right, our first real coach for 6 reels. Time. It's crazy. It's 3 weeks in. We're really here for our first real class. Welcome. You'll have a good weekend. Yes. We are here. It is infection prevention and control. One thing I want to remind you guys of for the exam for Friday. Definitely important lab is the festival material in here. We're all Monday happy family, right? So when you were talking about washing your hands in lab, you know, that's the #1 preventable way to keep your patients safe and free from infections that they can get in the hospital. That may be a testable question on the exam on Friday. We'll probably bring that up again today, but so keep that in mind. You know, so when you're talking about how do you keep yourself safe when you're lifting and moving patients, keeping things at your core, lifting with a Hoyer lift whenever possible, having your friends and buddies come with you. And then I'm going to finish up the exam review today. I realized when I went to go finish up the exam this weekend, I tried really, really hard not to work on the weekends because they're weekends. And I went to go post the exam and I went, oh, because we're doing only 1 day a week, the stuff got switched a little bit from last summer and there was about 15 questions. I was like, oh, we don't cover that until next week. And that wouldn't have fair. I have to rewrite the exam just a smidge. And I plan on finishing that this afternoon and then getting that to you guys. So you have the review by this afternoon. Fingers crossed. So don't forget QR code for attendance today. And then we will start talking about infection prevention and control. It'll be up again. Okay, so feel good for today. Encourage yourself, believe in yourself, and love yourself. Never doubt who you are. Remember that as you're going through this program, there will be ups and downs. I know that some of you were very, very pleased with how you performed on Friday, and others not so happy with how you performed. That is okay. This is your first exam. I had some emails that I have not responded to yet. Please do not hesitate. We'll reach out, we'll chat. We can have some conversations about ways to improve. There's always room for improvement, right? So don't forget, never doubt who you are and why you're here. You earned the right to be here through all of the work you did before getting here. So don't let one exam make you feel like you don't belong here. Okay, food for thought. Oh, look, there it is again. What is the #1 way you can prevent hospital-acquired infections in your patients? Hand washing. Hand washing. Yes. We're going to drill this into you over and over and over again. And if your patient says, did you wash your hands? Because people are getting a little more savvy. Yes, I'm going to wash them again in front of you. Not a problem. Don't get defensive. Just wash your hands again. Put hand sanitizer on again. It's not a problem, right? Okay, so we have professional standards and guidelines that kind of oversee us, depending on where we work. Centers for Disease Control, CDC, they're going to be like our overarching stuff when it comes to the big, bad, ugly stuff. So think about COVID, think about our flu vaccines every year, think about our general vaccine guidelines. Kind of been in the news lately, given what's going on. Our Agency for Healthcare Research and Quality, AHRQ, we see that as a point of how are we improving what we're doing and who's doing the research. The Joint Commission for Quality and Safety Education for Nurses, otherwise known as Joint Commission. They oversee a lot of our hospitals and are together with Centers for Medicare and Medicaid. They make sure that the facilities that you are working at and the patients are well, they are cared for to a standard. The joke, if anybody has been on TikTok, is that the Joint Commission only cares about whether or not you have food and drink at a nurse's station. Sure, I can get on board with that because I have been through several Joint Commission reviews of facilities, but really they look at other things too. Are the medications that are in your Pyxis, are they expired? Do you know, if I came up to you and asked you a question, do you know where the policies and procedures are for X, Y, and Z? Do they know, do you as a nurse in that facility know how to keep your patients safe? Those are all very important aspects of how you function as a nurse. It's more than just this, I'm going to go into a patient's room, I'm going to interact with this patient, I'm going to do the things I need to for this patient. We think about all the other things that we do with our patients. It's not just this single operation with one person at any given time. Think about when you see that, if you've ever gone to Cirque du Soleil or gone to a really amazing, well, I think it was circus, and you see that one person who's balancing on a ball, and then they have the sticks and they have the plates twirling and all that. They're just really amazing. You're like, wow, that's a nurse. Because they have all the different things that they are keeping in mind. They're looking at the patient's health and well-being. They're teaching them about new medications they may be on. They're teaching them, or they're giving them new medications they may never have taken before, and they're looking out for allergic reactions. They're looking for changes in vital signs. They're watching them for the potential for decline. So with all of these lists of things that we're doing, and we're watching out for each other and the other people that we're working with to ensure a safe working environment. And that's where the American Nurses Association comes in, as advocates for not only fellow nurses, but also for the environment in which we work. So I highly encourage you guys to join. As students, you can join the American Nurses Association. Last time I checked, it is free for students to join, or you can join the National Student Nurses Association for a small fee. But advocate, advocate, advocate. So here's that nasty healthcare associated infections, otherwise known as nosocomial infections. Turns out when we call them nosocomial infections, nobody knew what they were. They just sounded like this thing. But we want to say no to nosocomial infections. These are infections associated with healthcare in any setting. We say hospital-acquired infections, but really it is spread through the hands of healthcare providers. So we're in one room, taking care of a patient, leave that room, go to another room. Maybe there was hand hygiene, but it wasn't the best that it could have been. But it isn't necessarily at our hands. We take other things with us, like our pens and our stethoscopes and our nasty, nasty shoes like that. You know, by lots of people, will come into their garage, and lots of folks have like their laundry room as you go into your house. They literally have a change of clothes in their laundry room and just strip them with their stuff right into their washing machine. All right, here's the attendance QR code, if you didn't get it. So some important things to know, and this just takes us just like a little reminder of what we had in either micro, A&P kind of things. A pathogen is any kind of organism that is capable of causing disease. You may also hear referred to as an infectious agent. So influenza, influenza A, influenza B, think about COVID-19, staph. We have lots of our favorites that show up often. We don't like them. We don't want them around. We want to kill them as best as possible, right? So the things that we can kill. Think about what you learned in lab when you have to do different like airborne precautions versus contact precautions. We're going to talk about that here in a minute as well. Communicable diseases are any disease that's transmitted from one person to another. And we look at it because it increases the risks of morbidity and mortality. Now, with our patients who have other comorbidities, so you have one person who may have contracted, we'll look at influenza A, and they maybe just have a mild cough and maybe some stuffy nose and just feel kind of miserable. And then we have somebody else, maybe they went to grandma's house for Mother's Day, but grandma has type 2 diabetes and hypertension. They didn't feel too bad, so they were like, it's not that big of a deal. Grandma didn't get the flu vaccine because she heard on the news that it really doesn't help very much. And she didn't think she was watching the wrong kind of news channels. And she didn't think that it was that big of a deal. And so she didn't get the flu vaccine this year. Grandma, with her comorbidities of hypertension and type 2 diabetes, gives her grandkid a hug. I love you, let me feed you, let me feed you, even though it's Mother's Day. Gets coughed on, maybe sneezed on, and comes down with influenza A. Now, grandma, who already has a weakened immune system because of type 2 diabetes, gets much, much more sick than grandkid who has no other medical problem. We see an increased risk of morbidity and mortality because of her other issues. Does that make sense? And she's more likely to get sick than anybody else who was there. There could be other grandkids, his mom or her mom, and who don't have other comorbidities, and maybe they get sniffles, but nothing else. Then when we look at infectious diseases, they come in all sorts of shapes and sizes, viral, bacterial, fungal. They are commonly communicable, but they don't necessarily have to be. And are they communicable from person to person, from water to person, from fecal oral? What is it? How are we getting it? So the chain of infections. This is what we want to break. It's made up of 6 links. And in order for somebody to get sick, all the links must be present for the infection to be transmitted from one person to another. So first we have to have that infectious agent. So we have to have that bug, whether it's bacteria, fungus, virus, whatever it is, that has to be present, which makes sense, right? We don't have it there. It can't happen. So our first chance to break the chain of infection is to wash our hands and get rid of it. Or in the case of C. diff, what do we have to do with C. diff? Can we just use hand sanitizer with C. diff? No. Just those Sandy wipes. Sandy wipes don't work with C. diff either. They have to have those special bleach wipes. The C. diff is big nasty bug. Then we have to have our reservoir. So where can this beautiful thing grow? Where can it survive? Where can it multiply? What kinds of things do we find those infectious agents in? Here's some examples: soil, water, food. What else? Throw it on the human body. Hands, nose. Mucous membranes is our favorites, right? Think about when you sneeze and it's all just hanging out in here. So you want to sneeze here, cough here, right? Because then you're not sneezing into your hands and then spreading it all over the place, right? Mucous membranes include sexual organs, and they thrive there. Think about folks with UTIs, how quickly that can go very, very bad. And then don't forget about our aerobic and anaerobic types of bacteria, whether or not they need oxygen or can survive with little or no oxygen. So now we've got our infectious agent. It has a place to grow and thrive, but now it has to have a way to get out. So how's it getting out? Well, we have tons of different ways to get out. We talked about some of them because it can include the same place as that reservoir. Are we sneezing it out? Breast milk, urine, are we puking it out? Diarrhea. Can be a break in the skin. Pus coming out. Respiratory tract secretions, but it can't be an RT. Everybody has their thing. Respiratory tract secretions tends to be my thing. Like I can do lots of things, but that gurgly sound from respiratory tract stuff is like gross to me. Yeah, I can do all the rest of it. Like you puke all the time, no problem. Diarrhea, no problem. The big. All right, so it's coming out, right? Somehow that infectious agent is making its way on down, right? It's coming towards us. But how is that mode of transmission coming? Well, contact is going to be the best, the most frequent, and the most effective. Direct contact means I am putting my hands, something, we are touching. We are somehow touching that thing. Indirect contact means something had it on it, and then I touched that thing, which is where a lot of our hospital-acquired, healthcare-acquired infections happen. Think and stethoscope, the phone we carry, because that is a vehicle that's just covered in crud. Direct contact, think I was starting an IV and blood shot into my eye. That is direct contact. Sexual contact, mom gave birth to a baby. That makes sense. Then we start with the different other types of transmission. So we have airborne transmission. This is our tiny little organisms. They can travel. You guys were learning about making a bed, shaking out those contaminated bed linens. Absolutely not. Spreading that stuff all over the place. Key examples with airborne transmission are going to be measles, tuberculosis, varicella, or chickenpox, / shingles. But also simply sweeping the floor, because you're stirring up that dust, whatever is in there. And depending on how long that organism lives, it can be a huge problem. In tuberculosis, there's lots of different strains. The one that we are really scared of often involves our lungs, right? I have a close friend of mine, she's a nurse that I worked with. I'm pretty sure that she was a nurse with Florence Nightingale. Actually, I joke, but she just retired after 60 years. We worked together at Penrose, Maine before I became a nurse. And she was cleaning, she had a rental apartment. She was cleaning her rental apartment, doing lots of, she's the type of person who gets down on her hands and knees, scrubbing. She nicked her hand on like a nail on the floor. She didn't know it was there, and like nicked her hand, and she's like, oh, that was weird. Didn't think anything of it, just kept cleaning. She tried to put a Band-Aid on it, but it kept falling off, and she's still in water and stuff. She finished up what she was doing, and a few days later, she had this really nasty, like, gross infected hand. And she was like, wow, that is really bad. She went to her doctor, and her doctor said, yeah, let's put you on some antibiotics. I think it's just like it's probably just a simple nasty. We'll just treat it like it's just an infected wound, and we'll go from there. 2 weeks of antibiotics, didn't touch it, ended up sending her, after another 2 weeks of antibiotics, sent her to infectious disease finally. It was a strain of tuberculosis. By the time they finally figured out what it was, it had gone and infected her whole hand down into her middle finger and had wrapped itself like around her tendons and ligaments in her hand. It was the craziest thing. She still deals with it to this day, has a ton of scar tissue. I didn't even know that those were things that still happen. So when we talk about things living in the dirt and in soil on other materials, that was a very virulent strand of a microorganism that just saw an opportunity. So, when a patient tells you something, put that information in there, because that kind of documentation can give you data that a savvy provider will go, you know what? That is something that can lead them down. And it wasn't until she told the infectious disease doc that she had nicked her hand on the nail that they finally started doing additional testing on her. So just some weird things. So those bugs can be tricky. All right, so a vector is, along with the mode of transportation, this can be an organism that carries a pathogen to a susceptible host. So think about mosquitoes with West Nile virus. Does anybody know what else mosquitoes can carry? Malaria, yeah, that's another really big one. That's, so if you travel to a malaria prone area, they'll put you on anti-malarial medications before you go. Which can be really hard on the gut. For portal of entry, this is how do they get in? So for the person who is getting sick, they have to have some sort of opening, right? Well, we have our natural ones, jump above our eyes, mouth, nose, anything that's just open, right? But then we also have our any abnormal openings. Do we have any cuts, scrapes? Has there been a recent surgical incision? Did you get bit by one of those nasty West Nile virus carrying mosquitoes? Or ones that we did, like an IV catheter or a urinary catheter that was not put in well. But even if a urinary catheter was put in with the best sterile technique, that still is a site that can lead to an infection. So we still want to be really cautious with those, especially to really good cleaning and cath care with those. So what is that portal of entry? How is that getting into that person? Keep in mind, your patients you're caring for oftentimes have comorbidities, which are going to make them more prone to whatever that portal of entry is. They're more likely to be susceptible to whatever that bug is. So our susceptible host, think about your patient that you could be taking care of. You guys are going to go and do clinicals this semester with long-term care facilities. And lots of people go, oh, I don't want to go to a nursing home. These are some of the most complicated, fragile patients you will take care of because they have a ton of problems. They have so many things wrong with them. This is a susceptible host that could have one little thing send them over the edge to have a lot of problems. So think about if they get exposed, maybe they scrape their arm on the door as they're leaving the dining room, and now they have an open wound. They don't say anything to anybody, and because it's the door, 100 people have touched it in the last 2 weeks or more. And man, that organism was just ready to pounce, right? So we have the virulence of the organism that we're worried about. We have how many of that organism was transmitted. Well, if it was as concentrated as a nasty door in a, I don't know, Target, Walmart, King Supers could be, that could be hundreds of thousands of organisms were transmitted. And then how well can that host defend against that organism? Well, if it is a 17-year-old high school football player who's getting ready to, is gearing up for the season, they are probably really well equipped to defend against an infectious organism. But our 98-year-old with a laundry list of medical problems, probably not so much. So what does that look like for our susceptible hosts? How quickly will they become sick from that? So when we look at our factors that increase the risk of infection, our number one thing is going to be age. Our very young and our very old fall into the categories of, oh, we're worried about them. Breaks in the skin increase risk. Do they have other illness, injuries, chronic disease, disabilities? What else is going on in them? We look at substance use, smoking, multiple sexual partners. These end up being like risky behaviors that increase the risk of infection because you're being exposed to more chances of infection. What kind of environmental factors impact that patient? Are they exposed to extreme heat or cold that impacts their body, causing them to be dehydrated? What medications are they on? Are very old? Are they on 15 different medications? And then when it comes to nursing and medical procedures, what are we doing to them? They just have a 6-hour surgery and they were under anesthesia. We starting IVs, or putting Foley's in, putting an NG down. What are we doing? Every medical procedure has a risk associated with it. And I often joke that we can teach monkeys to start IVs. We can teach monkeys to put in NG tubes because it is a skill. It is a physical skill that you do. What you guys need to know is the why. Why do we do it? What is the reason behind it? What are the indications, the contraindications? What are the safety aspects of it? What is the therapeutic communication that you're going to tell your patient as you're about to shove a tube down their throat or up their nose, down the back of their throat? And I'm really sorry, it's going to gag you as I do this. So when you put all of those pieces together, sure, anybody can learn the skill aspect of it. But it takes a lot to put all those pieces together. So then if these are the things that increase the risk of infection, then we should know what helps to support defenses, right? Well, adequate nutrition. We want to help manufacture those cells of the immune system and say, okay, go immunity, you can do it, right? Let's say you got this. So think about the last sweet little old person that you saw, and Professor Nichols does not count because she is a superhero. She is like wearing a cape and she does not count. I honestly think that she's like age indeterminate. And I think she's like 700 years old, but nobody dares ask her because she's so amazing. No, think about like that sweet person who's like walking really slow at the grocery store, and you're like, oh my gosh, man, your bones are gonna like break in half, right? Versus the one that you know who's super spry, like Professor Nichols, who probably could run circles around all of us. I mean, honestly, I think she could still run a code if she needed to. What is the difference? Part of it is, what is their immune system like? What are they doing? How are they maintaining that? We have to balance hygiene. So here in Colorado, we have a problem because we're at minus humidity, right? So we kind of are always watching out for our skin, making sure that we're not so dry that we're like causing skin cracking. But we need to make sure that we're washing our hands, showering, bathing to decrease that bacterial skin count, which we all have. There's always bacteria all over our skin. But not so much that we're causing cuts and scrapes and grossness because we've just gone crazy. Rest and exercise are important. So much so that exercise is on there again. Reduce stress. The really funny part is reducing stress is going to come up in almost every class you guys will take for the rest of the time you're in nursing school. And then we always chuckle because you guys will be stressed for the entire time you're in nursing school. So just chuckle, move on, and be like, yes, we can be less stressed when we're done. And then immunization that's appropriate for their age and situation. So obviously when you have a 3-month-old, their immunization schedule is going to be different than a 30-year-old, which is different than an 80-year-old. So immunization according to their age. All right, so remember that we want to prevent infection by breaking that chain. There's the 6 parts of that chain, and we can break it at any point, but really the easiest part is breaking it by not giving it a place, not giving the bacteria a place to thrive, which is why we wash our hands. Now, when it comes to classifying infections, we're going to look at the location and the duration. So localized infections are going to be a specific body site or organ. So think about, he has a left lower leg wound infection. You have a simple ear infection, or they have a surgical site infection. Versus a systemic infection, which impacts the entire body and has been carried via the bloodstream. You may also hear if they've had like bacteremia or septicemia. So that means that bacterial organisms are present in the blood, that's bacteremia, versus a symptomatic systemic infection in the blood. So those are ones that we'll go into in a lot more detail once you get into MedSurg 1 and 2. So just know that these are just, that person is very simple. And then we look at the duration. So acute is rapid onset and fairly short duration. So think about your common cold, even a small wound. It's not necessarily classified as acute, but if we know that it is acute, it's short, shouldn't last too very long, versus chronic, which is slow to develop and has a long duration. We think of acute anything less than 6 months, chronic anything longer than 6 months. The example that they use here is rheumatoid arthritis. But you also can put into this category, because rheumatoid arthritis is not an infection. Epstein-Barr virus would fall into chronic, or when you look at an infection. And then latent would be an infection that is present with no discernible symptoms. So an example for that would be HIV. Not AIDS, because once a person starts to have signs and symptoms, then they have crossed into the AIDS category, so would no longer be latent at that point. So we have acute, chronic, and latent. And then for stages of infection, we have the incubation period. This is the time between when somebody has had the invasion of the organism and the onset of the infection. So they don't know that they are sick yet. The bug is just chilling, waiting. It's doing its thing. They're starting to grow and multiply. And then the length of the incubation period is going to depend on what that what that bug is. The prodromal stage is the time at the beginning of non-specific symptoms and specific symptoms. So think about when you're first starting to get sick, those non-specific symptoms are going to be fatigue, like general body aches, maybe a low-grade fever. Another example they use is lethargy. I don't really like the term lethargy because when we truly see lethargy, you are like virtually non-responsive. So I don't really like the term lethargy. But that just general feeling of unwell, and you're just like, this don't feel good, right? You can't really put your finger on it. Maybe you have like a slight headache, or a little foggy. You just don't feel great, right? And with many of the pathogens, there's a good chance you are contagious during this non-specific prodromal stage. And then the prodromal stage could be a few hours to a few days, depending on the pathogen. Once you are in the illness stage, this is where the specifics of that illness are exactly what they are. So, say it is varicella, you start to have the chickenpox, you start to demonstrate that very classic rash, elevated temperatures, maybe there's some nausea. So those specific symptoms that are known for that disease process are there. You may still have some of those non-specific generalized fatigue, headache kind of stuff, but the very specific ones that are known for that pathogen are there. That's during that illness stage, and you are contagious during that stage generally. And then as the illness takes its as it's running its course, you'll slowly move into that convalescent stage. So here's an example of the stages of illness out for those who are more visual. So we have our incubation, prodromal, the illness with more severe signs and symptoms. They added in a declining where those signs and symptoms start to decline, and then the convalescence where there's no signs or symptoms. This is where we start to see the organisms approach zero, and it may take several days or months to happen. So you guys don't have to raise your hand, but anybody who ended up having COVID at all during our fun time with COVID, this would have been possibly what you felt. And for those who needed to test negative to go back to work, this is where that problem with convalescence came in, because you tested positive for COVID for a long time. Yes.
Just a fun little story, like, I was actually hospitalized for COVID, and I got put in the hospital after my 14th day. I got hospitalized on day 15, and was there for like 3 days. So like, it's not check.
Well, but so COVID was weird because there was a aspect of COVID that they saw a resurgence of symptoms in that it kind of like you'd start to feel better and then it would ramp up again. Just all of a sudden got worse. Yeah, COVID had, and it depended on which, was it with the 2020 or was it later 22? There was several times. Yeah, it was, COVID was a weird situation. Because we had, you can see with that hump, like you could have been in that tall, and the time, they don't even put like a time, it's just across time. Like this could be hours if you have one of those 24-hour bugs, this could be months. I mean, I guess technically, because I'm still on oxygen and I had COVID in 22, am I still convalescing? Because I'm still on oxygen from COVID? I guess technically, but I still have signs and symptoms because my lungs are down. And I, according to my CAT scan, have post-COVID changes. And I can't do anything. So, you know, I think COVID changed the way we look at illness for sure. So, okay. So we have our natural defense against immunity. We have innate. These are some genetic factors that we're like, yes, I can fight this off because I was born a superhero. And I have these genetic factors that mean I can fight off this bug. And we actually don't understand a whole lot about that. But they're there. Then we have acquired. Active is our own antibodies. We were either naturally exposed to them because we already got exposed to that infectious agent. If you are of a certain age, you might have gone to chickenpox parties when you were little. Yeah, you know, somebody in class got chickenpox and the moms all said, everybody's going to that friend's house and have a chickenpox party. We're just gonna let chickenpox run rampant through that class and we're gonna have fun. We don't do that anymore. Now there's a vaccine for it. You know, some of y'all missed out on some good times because there was like snacks and video games, okay? And well, I guess it was board games, not so much video games. So I think that's the best one I can think of because it doesn't sound as crazy as some other naturally exposed infectious agent. Artificial immunization. So we get immunized for polio, thank goodness, and other immunizations along our recommended route. And then there's passive or ready-made antibodies. These are ones that we get when we are born. Thank goodness. Mom gives us some antibodies when we're born so that we can survive the first few months. Otherwise, we are just all on our own. And then we have some artificial passive antibodies that are from other sources. Oh, sorry. We also have normal flora. That's hanging out within us. It is beneficial and essential to human health and well-being. We are learning more and more about the normal flora within the human gut. I think this has taken off probably in the last 10 to 15 years studying what happens within the gut and how amazing that the synthesis is. It limits the growth of harmful bacteria. It's partially by competing with them for other available nutrients. It's just like, no, you can't have that. We're going to eat it first. But also the bacteria in the intestines helps to synthesize vitamin K. So if we don't have it, you can't synthesize vitamin K. So think about, I know I keep saying C. diff, but C. diff completely trashes, after you've had antibiotics, you trash your normal flora in the gut, and it's been overrun by C. diff. Our patients also struggle with bleeding because they lack the ability to synthesize vitamin K as well. And so one of the treatments for C. diff that they cannot get rid of is a stool replacement. Somebody volunteers their stool. Yes.
That used to be like a surgical procedure. Now I think it's just, they do like freeze-dried.
Yeah.
Those the people's health.
Yeah. They like dry it out and just pop a few food pills. But so think about, well, first of all, has anybody ever taken care of a patient with C. diff? It is a very distinct smell. A. B, the amount of stool that can come out of a patient with C. diff is shocking. Like, seriously. So by the time somebody has had it for a little bit, they are willing to do just about anything to get rid of it because they are so miserable. And it's so uncomfortable and their poor backside is just torn to bits. And it is like acid coming out of their rear. I mean, it's awful. So, I always feel like, oh, I don't know I could do that. But I also have never been in that position where it is so, you're so torn apart. So, knock on wood, thank goodness. Like, that would be awful. So probiotics help before, but generally not, once you have C. diff, it is messed up. That's why a lot of providers will recommend that when you are on antibiotics, that you take probiotics with it to help counterbalance, keep things going that way. But it's important to do live cultures, not just random. Probiotics. All right, so our primary defenses, we have anatomical features that limit pathogen entrance. So think about our little hairs in our nose. Our tears will help to get stuff away from our eyes. Even our eyelashes help with that. The normal flora in our GI tract as well as our urinary tract. And then when we cough, that helps to keep stuff out of our lungs. Intact skin is really important for primary defense. And then our secondary defenses are very important. That's activated by chemicals released by the pathogens. That's phagocytosis, where our WBCs called phagocytes start to just attack and destroy those pathogens directly. There's complement cascade that triggers the release of those chemicals. And those chemicals release inflammatory mediators as histamine. So it's a full process as that starts, which leads us to inflammation and why inflammation happens around, we're going to take, for example, a wound. Inflammation is not the same as an infection. They can get confusing, but they are not the same. So with inflammation, there's the release of histamine and other inflammatory markers. This leads to vasodilation and increased capillary permeability. So this is taking you back to A&P and what happens when those capillaries are more permeable. So if something is more permeable, what happens? If it has liquid near it or around it, it's going to ooze out, right? So think about what's inside the capillaries. We have blood in there, right? So stuff's going to ooze out. Blood's going to ooze out. Okay? Inflammation causes increased flow of white blood cells, nutrients, and oxygen to that area. So if we have a pathogen, then let's say we have that open wound. Pathogens came to that open wound. And they said, oh no, this is a bad thing. Inflammation starts, that release of histamine starts with those first few little phagocytes going, I'm going to eat you up, right? It leads to vasodilation of that area, increased capillary permeability. Those more white blood cells come, more nutrients, and more oxygen to that area. Now, all of a sudden, we're starting to see signs and symptoms of infection. We have pain. Guess what? We now have increased histamines and prostaglandins happening around that area. That inflamed tissue, all that inflammation that's happening there is putting pressure on the nerve endings in that area. Redness happens because of increased perfusion to that tissue. Warmth also happens because of increased perfusion. If that wound is open, we can have drainage. Phagocytes are eating stuff up. Gotta go somewhere. There can be a rash depending on what's happening. Generalized malaise, anorexia, fever, diarrhea. That release of histamine and prostaglandins, depending on how widespread that critter is, can make somebody feel really ill. So we need to teach our patients about the signs and symptoms of infection. We're gonna teach them Rita. Redness, edema, ecchymosis. What is ecchymosis? Anybody know? Bruising. But that doesn't fit in with Rita's. We're gonna go with ecchymosis. Drainage and approximation. So approximation is how well is that wound coming together? So that's specific for if you have a surgical wound. Is it coming together really nicely, or is it like all jaggedy thick? Or is it starting to come apart now? Let's take a 10-minute break before we get started on the next. So we'll be back at 10:30.
Scroll down.
No, what comes out of those? Here's a fun.
Bless you.
Kind of service them we get. Inflammatory exudate. So once those WBCs and dead tissue start to accumulate, they gotta go somewhere. And that collected group of gunk is exudate. So we have to label something so that you can document it. And describe it to the next person who would be looking at that wound. So we have serous, which is clear. That is mostly plasma. It's just, so think about if you had a blister and it's like this little, little blister, and if it were to do something, it is just clear, nothing exciting about that. Sanguinous is red, that contains red blood cells. We can combine those two and call it serosanguinous. It's a little bit of plasma and a little bit of red. Serosanguinous, so that's together. And then we have purulent. Say that 5 times fast. That is pus. That is gross. That is not what we want. And that contains WBCs, bacteria, all the things that are happening within that. And that can be all different shades of color, from light yellow, straw, pea green, take your pick. How do you want to describe it? Okay. And then here's another, if you want, you're a more visual person. Cirrus. Clear, it's usually very, very light in color, thin, watery, pale yellow. It should be odorless, very important. However, if we do have higher amounts and it's not a burn, we worry about a fungal infection. Burns, it is expected. And sanguinous, mainly blood. Serous sanguinous, that's where we have plasma and blood. Then purulent. Brown, gray, yellow, green. Smells not great. It's always abnormal. It indicates an infection. Report and culture. If you have something that looks like that and it gives you the gift of a culture, take the culture and thank the culture gods. Because when in doubt, culture it. Even if you do not have an order for a culture, if it has not been cultured yet, take the culture, and then when the culture gets ordered a few minutes later, you already have the culture. Okay, and then tertiary defenses, the body's immune system says, you know what? We know we need to destroy pathogens, so we're going to work on coming after them, but this is going to happen a little bit later on. We have those primary, we're going to go after it with fighting with WBCs, but this takes a little bit of time to get that coming up with humoral immunity, those B cell production, and cell mediated. That has a little bit of time before it starts to happen. With the first exposure and then second exposure, that's going to take time to happen. There's direct destruction that happens with cell mediated of infected cells by the T cells, but we're going to wait on whether or not that they decide, yes, this is for sure something that needs to be destroyed, versus humoral immunity. The B cells have to have had exposure, then see it again for the antibodies to have been produced. So let's talk about fevers. Good, bad, or indifferent. You like the patient who says to you, oh, 99, that's a fever for me. Not in healthcare. Don't tell them that. For us, 100.4 and above is fever. Okay. Anything from 36 to 38 degrees Celsius is normal. Below is hypothermia. Above is pyrexia or a fever. Fevers generally mean the body is trying to fight something off. Body says, you know what? I'm mobilizing the immune response and I'm going to fight. It's trying to kill off an organism. Now you do need to keep in mind, like if your patient comes in with a fever and they have been out, hanging out the Great Sand Dunes and it was 115, that is not a fever, that's heat exposure. Okay, so do utilize critical thinking about what's happening with our patient versus our patient who had generalized malaise, nausea, vomiting, body aches, and now presents with a temperature of 38.2. Now we're dealing with a fever, right? So One of the really wonderful things is fevers also help to enhance the effects of antibiotics, decreases plasma ion concentration, and limits the growth of our microorganisms because they can't thrive in higher temperatures. That does not mean we do not treat a fever, because bad things happen when we have higher temperatures. But we generally do not treat temperatures that are below 100.4. Do you feel good when your temperature is 100.3 or 100.2? No. No, you generally have chills and body aches, feel gross. But that is okay because the body is fighting off the bacteria, the crud, the organism, whatever that is in there. That is okay. Fine. We start treating higher. All right, so when we're looking at infection prevention and control, we want to start utilizing the nursing process. Look at things through your patient's eyes. What is the status of their defense mechanisms we just talked about? What is their susceptibility? Do they have other medical therapy that's going on? What is their clinical appearance? Do they have signs and symptoms of infection? And then what does their lab data tell us? Somebody asked earlier, do we need to start memorizing lab values now? No, you do not have to have them memorized, but I highly recommend that that be part of your starting to look at them, know what they mean. Do I expect you to right now be able to tell me that a normal white cell count is between 4,000 and 11,000? No, but it is helpful as you're moving forward to start adding that to your repertoire. So our assessment includes investigation. What data collections do you want to know from your patient? I want both subjective and objective data. Our assessment of our patient begins as soon as we walk in the door. We are literally listening and feeling all the things about our patient. What am I smelling? Do I smell C. diff before I walk through the hallway? Am I hearing a really nasty wet cough? My patient looked flushed, their cheeks bright red. Are they curled up on the bed like they're hurting and in pain? Are they sitting in the bed, chatting on the phone, eating hot Cheetos and drinking Dr. Pepper? What are they doing? What does the data tell me? What do their vital signs tell me? What is the hard facts that I have about them tell me? And then we look through body systems. You guys are going to start going through an health assessment. That's literally head to toe. What does that tell me? Travel history, that's a really good indication of, have they been someplace that's high risk? Did they just come back from a malaria-prone zone? Someplace where we're seeing Ebola or West Nile virus or Zika or a pocket of TB in the United States. Are they up to date on immunizations and vaccines? And identifying early risk factors. Do I have somebody who has a lot of comorbidities? They have hypertension, type 2 diabetes, COPD, and they're on 10 different medications. And they tell me their cough is worse, they're tired, and they're having to use more oxygen than they normally do. Man, that's a recipe to make me really concerned. And then we start looking at our nursing priorities. So you guys started on, or you're going to start these tomorrow in labs. We start looking at what our priorities are. Well, if I'm concerned for my patient based on what they're reporting, risk for infection, well, what does that look like? If my patient had surgery and I cut them open, we cut them open, had a big abdominal surgery, we gave them a wound, they're at risk for infection. If they are immobile, risk for impaired skin integrity. Impaired mucous membrane. I have a patient who has cancer and is being treated for with chemotherapy, and they have a bunch of wounds in their mouth because of that impaired oral mucous membrane. They're not eating because of that chemotherapy. Imbalanced nutrition, that's the body requirements. Social isolation. Readiness for enhanced immune status. Maybe that patient said, oh yeah, I know I'm due for a pneumonia vaccine. Can I get that before I leave? Absolutely. Readiness for enhanced immune status, immunization status.
I have a question.
Yes.
So I know somebody who just recently like went into the hospital because she thought she had pneumonia. They found the blood clot in her leg. While they were trying to treat the blood clot, her hand was like swollen and purple. They treated the blood clot, and now 2 of her fingers are necrotic and she's gonna lose the fingertips. So since they didn't treat the fingertip or like treat the hand when she was like complaining about it, would that kind of go into like their blood clot more important to them, even though she was like complaining of her hand, or would that be like kind of stopping the ball?
I don't know the circumstances, but it seems like they should have done something with that hand. Because, so just because your primary complaint is of, leg pain or whatever, that doesn't, you don't just have a leg in the med. You are caring for the entire patient, the entire body, everything that is there. And your patient, if she had said, I'm suicidal, we're just going to ignore that? No, she's getting put on a watch until proven otherwise, right? So obviously I can't speak for the situation, but just because it doesn't go with the chief complaint doesn't make it, you can't just disregard it.
They just get rid of ice. Hold that in your hand.
The bird just, the bird didn't even agree with that. Yeah. I mean, that could be like your initial thing. Well, I'm not sure what's going on. I'll give you an ice pack and I'll let the physician know so they can look at it when they come in. I mean, but somebody's fingers should not be purple. Yeah, like that.
It was like it looked like she had like she had a whole picture like the process of what her hand looked like.
And she already has a clotting problem. We know, like, so this is where critical thinking, obviously, okay, I don't know, I'm being recorded, I have to really I don't know exactly what happened with her, but this is where critical thinking comes into play. We know she has a clotting issue. Blood clots do not happen in a vacuum, they happen to the entire body, right? It's not like, oh, I'm just gonna clot in the leg and I'm gonna be fine, right? No, that's a clotting condition that's happening to the entire body, which means if she has a clot in one place, she could have clots in many places. The fact that she was demonstrating some sort, in my mind, my first thing went to, oh, she had some sort of arterial occlusion. Is that your first thought? She's an experienced nurse as well, working on, I don't know if I introduced you, I'm sorry.
It's okay.
Do you want to introduce yourself real fast?
Yeah. My name is Samantha. I'm in the Master's of Nurse Educator program, so I'm getting my clinical hours,
Just hanging out with us.
hanging out. I'll be teaching some
Yeah.
coming up.
Just like how we have Ben in lab, she's in here. So that, my first thought was, I wonder if she had some sort of arterial clot in her hand, because that can be incredibly painful. you have swellings. So my very first thought would be to assess. Because anytime you have something different, you want to assess. Do what you think your intervention could be to change, which would, fine, I'll apply ice. But if that swelling didn't change in a reasonable amount of time, say 20 minutes, half hour, I'm gonna let the provider know. And I'm gonna document a lot. Does she have pulses? Does she have good cavities? If she does not, I'm gonna document some more, and then I'm gonna let the provider know some more. Because that would be my concern. But do you see how when you're starting to put pieces together, that it's more than just, we're not just talking about the fact that she had a clot in her leg, we're talking about all of the other things that could be going on. So and then outcomes can be poor if we don't follow through as nurses. You know, and maybe that initial nurse was there for that one day, passed on the information and it didn't go anywhere, which can also happen. But this is why I document a lot, because if that first nurse gets called in court because it was maybe not appropriate care, she can be like, I passed on the information, you can see from my documentation. I let them know, I applied ice, I let the provider know. And then I went off shift and I did not take care of that patient again. I mean, again, I don't know the circumstances, but yeah. Okay, so when we're looking at the outcomes of a patient when they are prone to infection, what did we do to prevent that infection? Obviously, we're going to be washing our hands, cleaning up our spaces, wiping down our tools that we're using, whether that's our stethoscope or our pens, whatever. What are we doing to control or reduce that risk? Again, cleaning up our spaces. Are we educating our patients and their families on washing their hands, wound care, that kind of thing? What kind of maintaining resistance to infection can we help our patient with? We advise them on good nutrition choices. Can we help them on getting up and ambulating so we have good blood flow? Can we help them with turn, cough, deep breathe, and use the IS after they've had surgery? And then we look at verbalizing understanding. So if we have a patient who we're really having to impress upon them how important hand hygiene is, because maybe we've seen them not wash their hands after they've gone to the bathroom. And like, okay, it's very, very important to reduce the risk of infection that you wash your hands every time you use the bathroom. Then our outcome statement, rather than it saying we'll have a decreased temperature, we would say patient either verbalizes importance of hand hygiene after using the bathroom every time, or demonstrates consistent hand hygiene after using the bathroom. So either one would work. All right, so when we're looking at preventing infection, we want to implement medical asepsis. This is the state of cleanliness that decreases the potential for the spread of infection. This is a clean technique, not sterile. So understanding the difference between those two. And this is really just maintaining a clean environment, including hand washing. It's like we're just trying to beat you over the head with hand washing, right? Over and over and over again. So the difference between this is that we're utilizing our gloves when necessary, we're keeping our environment clean, we're wiping our stations down, that kind of thing, especially between these nurses. Clean up spills and dirty surfaces promptly, remove pathogens through chemical means, so our standing wipes. Please, for the love of everything, do not use the purple standing wipes with bare hands, red gloves, they're not good for bare hands. Remove clutter, anything that kind of cluttery in your space that contaminates space. So make sure that you're cleaning that up. And then consider any supplies that have been brought into a patient's room as contaminated. And anything from a client's home, those are also contaminated. So once something has entered a patient's room, that has to stay there. So if you take in a big bundle of supplies because you're going to do wound care in that room, and you take in, I don't know, 30 things of 4x4s. Those 30 4x4s are staying in that room, and even should just go home with that patient. Otherwise, you're throwing them away because they should not leave that room. They are contaminated with that patient's patientness. They should not be removed from patient to patient because those can't be wiped down. They're like a papery thing. If you wipe them down with a sandy cloth, you've actually made that worse. All the times you should be washing your hands when you first get there. Before you leave, enter and leave the client's room. And this could be either hand sanitizer or washing your hands, depending on the circumstances. Before and after contact with the patient, before and after contact with the patient's belongings, before and after using the restroom, after coughing and sneezing, before gloving, after gloving, before and after touching your face, before and after eating, after touching a contaminated article. The one thing you have to wash your hands is when you see visible dirt on your hands. And then here is our guidelines. This first one may be very appropriate for a test question. Wash your hands for at least 15 seconds in a non-surgical setting. 2 to 6 minutes in a surgical setting. At least 15 seconds in a non-surgical setting. Not 45 seconds, not 3 minutes, at least 15 seconds. Warm water, not hot. Apply soap to wet hands, use friction. That's all the goodness, right? All the goodness. Not all the way down here. We're not in the OR. Clean beneath fingernails and jewelry. Rinse the soap off. Are we going to be going like this? Already been all over the place. People next to us. Towel or hand dry. We don't even have that option. This building, it makes me sad. We're just gonna spray it all over the place with our lukewarm hand dryer. All right, here's a question. When caring for a patient, what is the most important step the nurse can take to prevent infection control? Oh, it's not even on here. Sorry, my bad. The answer came up after I did that. How about 4? All right. While performing incision care on a post-op abdominal surgical patient, which information would be an important step to emphasize for the patient to do at home? I have a couple people have answered. Yes, examine the site for signs of infection while cleaning the area. All right, so when we look at health promotion, which we're always working on for patients, one thing you're going to find out is nursing is a lot of education, and health promotion is a huge part of that. So we talk about immunizations that are appropriate for that patient's age. We look at hand washing and general hygiene. Cover your nose and mouth when coughing. Into the elbow is the most recommended. Nutritional support, so ensuring the patient has enough calories and fluids for their body, and then rest as necessary. For the CDC guidelines, we're going to start talking about precautions. So standard precautions is tier 1. These are the ones that we do for everybody. If it is wet and not yours, don't touch it without gloves. Standard precautions. Wet and not yours, don't touch it without gloves. Pretty easy, right? If it could be wet and it's not yours, don't touch it without gloves. So if you're going through a patient's belongings and you don't know what's in there, are you wearing gloves or not wearing gloves? Yeah, it only takes one time putting your hands into a bag of belongings that are wet, you're like, yeah, you'll never do that again. Or pulling linens off the bed. Gloved or not gloved? Absolutely. We don't know what's in there. You know, if you're not sure, gloved. Right? It's not hard. If you think you could have an exposure, like, man, this patient's been a little spitty. They're spitting. I think I'm going to wear a mask, and I think I'm going to wear goggles. Awesome. Wear them. Or, yeah, there's no harm in that. These are universal precautions. All needles, syringes, sharps, designated sharps container. That is a standard precaution. It doesn't matter if the patient is known to have certain infectious diseases. They go into the same sharps container. The only time that is different is when the medication requires certain disposal, like chemotherapy drugs. Not the type of exposure that the needle has had. So, wash your hands before and after patient care. A mask or protective eyewear should be worn if there's any sort of splashing that could happen. So, if your patient had exposure to, I don't know, some weird chemical into their eyes and you're helping them to do an eye wash, guess what? I'm going to be wearing goggles too, right? Gloves should be worn if you're going to touch something wet, right? I'm not touching it if it's not mine and it's wet. Gown should be worn if you are likely to become soiled. And if I'm helping that guy with their eye wash, I'm putting a gown on too because I don't want that stuff on me. And then all needles and syringes need to be and sharps into a designated disposal. Here's another visual for that. Blood and bodily fluids, we have the red container score. That depends on the amount. And that also will depend on your facility. For tier 2, this is going to be transmission-based precautions. You guys, we're talking about it here, but you also talked about it in lab. So we have contact, airborne, droplet, and then you have protective, reverse isolations. It's all the same. Reverse, they're the same. All right, so contact precautions. What do you guys remember about contact precautions from lab? Gloves. What else? I don't. Give me the answer right here. What else do we do? Gown. All right. Basket what? And face shield. If what though? If you're going to come in contact, right? So not necessarily. And then how do we how do we leave the room? And we'll dispose of everything before leaving the room. All right, and should the patient be hanging out in a room together with another patient? So private room. Unless they have the same organism, in which case we can double room them if we have to. What kind of examples are contact precautions? What's our most common one? MRSA. Yeah, MRSA is going to be our most common one, and then probably BRE. We're seeing more and growth, which is awful. They also list herpes and then RSV for our kiddos, which surprised me that went contact precautions. I just thought that was impressive. Double bag the linen, and trash needs to be marked as contaminated. Here's our airborne. What do we need for airborne? Mask fixation. What kind of mask though? N95. N95. What's our worrisome one with this one? TB. What kind of room should we have if possible? Negative pressure. If we can't have that, what's the most important thing we do in that room? Keep the door closed. Yep, absolutely. And then because we have, within this category, we have measles and varicella, it is a specific thing for our providers that are caring for them. The providers need to be immunized for whatever they're caring for. So specifically measles or varicella, they either need to be immune, they need to either prove they're immune with varicella or have had it and be immune, and then they have to have, we all get measles immunizations, but that has to be proven as well. So they should not be at risk. Very, very, very bad. So keep in mind that we always follow standard precautions, and then these are extra precautions on top of this. Okay. And then they're also private room. Okay. All right, droplet precautions. What do we have for droplet precautions? What are we doing for these guys? Mask. All right. What's the one that we see the most for this one? Influenza. Yep. We also add pertussis to this one. And then when we are transporting this patient, we would prefer to only transport when medically necessary. And the patient needs to wear a mask as well as the person who is doing transporting. We don't need them to be coughing all their nastiness all over the place. All right. So all of these guys, private rooms whenever possible, or only with the same type of organism. Standard precautions and then the extra precautions. All right, and then our protective isolation. Who are we protecting this patient from? Yeah, we're protecting them from us, right? So this is used for what types of patients? Are immune compromised. So they have low white blood cell counts. They can have, they're maybe undergoing chemotherapy. They can have large wounds that they're really struggling to heal. So we're wearing the mask. Sometimes it is as much as you're completely gowned, gloved, everything, depending on how low their white blood cell count is. Sometimes it's also called neutropenic precautions. You may hear that as well, if the patient is neutropenic. Private room, they should not be placed with anybody who has any other problems. They also get no live plants or flowers are allowed, and they should not have fresh fruits or vegetables because that can also be a problem. For all precautions, there needs to be a sign on the door, depending on what kind it is. The equipment needs to be available right there. Nobody should have to go hunting for the equipment that they're supposed to be using. There needs to be the bags available for them to be able to bag up all of the soiled linens and the waste. Sharps container in the room. Medical equipment for that patient needs to stay in that room until that patient has been discharged. So stethoscope, blood pressure cuff, thermometer, if they're on some sort of like special wound care, all of that needs to stay right there for them. All of that. They need to have a private bathroom or bedside commode if necessary, so that they are not leaving that room if to use facilities. And then please keep in mind that there is a significant psychological impact to be considered. A lot of what we do, and I think I talked about it when I talked about the art and science of nursing. A lot of what we do, therapeutic communication and therapeutic touch. Imagine for just a second what these patients are going through when they are not being touched by another human hand. They're being touched through gloves. They're not seeing faces oftentimes. That has a big psychological impact. So how you're communicating with them, your tone of voice, the things that you're saying really needs to be considered as you're caring for this patient. Maybe take that extra few minutes to pull up a chair, sit down, ask them how they're doing so that you can really see, are they struggling with loneliness? If maybe they have that big gaping wound, are they having trouble with altered body image? Are they feeling rejected because they're stuck in a room by themselves and nobody's allowed to come in? Are they feeling guilty because they have like really scary disease and they don't know what to do about it? So, ask them how they're doing. Then when it comes to infection control and healthcare workers, make sure that you are following your standard precautions. If you are controlled to bloodborne pathogens, minimize your exposure immediately. Wash the area thoroughly with soap and water. Notify your supervisor, or in your case, your clinical instructor. And then you'll contact infection control or the employee health nurse as soon as possible. And then you want to complete an injury report. Do not report the double-negative. Sorry. Make sure you report. If you choose to not report an exposure and end up with some kind of some sort of infection later on, it will not be covered under workers' comp, and that would be not great for you. So make sure that you report anything, even if you think it's the smallest situation. Some drug-resistant pathogens that we look at include methicillin-resistant Staphylococcus aureus, MRSA, vancomycin-resistant and enterococci, VRE, and our best friend forever, C. diff. That only responds to hand washing and bleach. I brought that up before. So hand sanitizer and standing wipes are a no-go. So just strike them. In fact, most of the time they'll actually put bags over the hand sanitizer and remove the standing wipes from anywhere close to the rooms that have C. diff, so that is a visual reminder that they can't post. For the nursing process, how are things going for the patient? Have the expectations of their care been met? Did they have outcomes that were measurable? Did the patient participate in those infection control techniques? Did the patient's actual response meet those expected outcomes? And then if those goals were not achieved, what steps need to be taken in order to accomplish that? So say we wanted our patient to participate in wound dressing changes, and by the end of our shift, but they were not able to yet. What needed to change in order for that to happen? What kind of steps do we need to fix for that? There's another one I didn't put the answer in there, sorry. Which of the following actions violates the principle that is key to proper hand washing? Shaking your hands dry over the sink. What is the problem with very hot water? So very hot water makes it to where it actually causes more damage to your skin, causes breaks in the skin, and you're less likely to keep your hands under the water and scrub the way that you should. So you're not gonna be like so warm enough to be able to do the scrubbing. But yeah, it can also cause burns. I mean, when you say very hot water, it's not tolerable hot. That makes sense. So we don't want to cause any burns. Don't really want to get into the next chapter. We only have 7 minutes till the break. Seems yeah. We break from 11:30 to 12:10. You guys are allowed to have lunch. Isn't that nice? No, we're in prison. What? You said allowed. I know you're allowed to have a lunch. It just sounded sort of or something. You're allowed. I'll allow it. How about we go to lunch and be back at 12:10? Don't forget, be back at 12:10.
Yeah, I think that's what probably, yeah. Actually, we're taking my girls. Yeah, but we make some back. It's fun. My gosh, that's really.
All right, jumping in to chapter 27. This is on patient safety and quality, which goes hand in hand with infection prevention and control.
And then.
So safety is the condition of being safe from undergoing or causing hurt, injury, or loss. That is courtesy of Webster's. This is a basic human need. We refer back to Maslow's hierarchy frequently. That is one of our lower rungs of Maslow's hierarchy, is that basic need for safety. And our patients need that feeling of safety in the healthcare setting, and they also need to be safe from themselves. But nurses also need to be safe. So that's something we want to consider when we're working. How are we attending to our safety? So keep that in mind. The risk management aspect, those of you guys who have other careers that involve some kind of risk management, this may sound very familiar to you because we do borrow from other jobs, other professions, and risk management is part of that. So risk, safety, quality cycle. We identify risks. We want to establish preventative practices. So let's not even have a safety issue happen because we're going to prevent that in the first place. That's why we put indwelling urinary catheters in a sterile technique, because we want to minimize the risk as much as possible for that patient to develop an infection. And then we ensure high quality patient care. We look at what the outcomes are that we want for our patients, and we work to ensure that that outcome matches the quality of care that we're giving to the patient in the first place. And that minimizes the risk of injury to the patient across the board, right? So if we are providing that high quality patient care from the beginning, then we're gonna minimize that risk of injury. What are we doing for that patient that gives us the best possible outcome? The quality and safety education for nurses, or QSIN, helps to define what future nurses need to know, what skills they need to learn, and what attitudes are necessary to promote safety across the board. And part of that is quality improvement always. We look at things that we're doing, the attitudes that we have, the interpretation of information, and we say, wait a minute, is this how it should be happening? Or should we do something better? So for a long time, we would just put Foleys in to anybody who we thought needed a Foley. Oh, you don't want to get up? Not a problem. We're just going to throw a indwelling catheter in and you can just lay here all you want. Oh, you broke your hip. You're going to be in bed for the next 2 weeks. Putting a Foley in. Here we go. And so we have these patients who deteriorated. They ended up with blood clots. They ended up with urinary tract infections. And we went, oh my goodness, this is not great. And through quality improvement and nursing research, we said, oh, this is not how it's supposed to be. Nurses have driven quality improvement in saying, we need to get these Foleys out sooner rather than later. And how about we not put Foleys in patients who don't need them? No, that patient can get up and go to the bathroom. So we no longer put Foleys in for the sake of convenience. Yes, there were the times in my nursing lifetime that we put Foleys in because the patients are maybe a little bit hard to get out of bed. It's just like a thing of convenience. And we have nurse-driven initiatives to get those Foleys out as soon as possible. The sooner we can get them out, the better it is for the patient. We also started having patients ambulate sooner after surgeries. Minimizes the risk of developing blood clots. Part of that is driven from QSIN. What quality improvements can we do that are nurse-driven initiatives backed by evidence-based practice that improves patient outcomes? There could be people in this room that are already finding those things, looking at what they're doing for patients, going, oh man, what if we did? Evidence-based practice at work. So we look at the environment, and this is kind of a broad scope of what's happening with our patient, right? So when we think about our patients, we're like, this is our own little world with our patients. Just us and our patients. But there's lots of different things that impact our patients and impact their survival, their ability to recover to the best that they can be, back to where they were beforehand. Having a safe environment is better for the patient and better for those who are working with that patient. And it says staff, but that really includes physicians, mid-level providers, all the adjuncts that work with patients, something for radiology, lab, and the CNAs, the environmental services, everybody that's part of caring for that patient. So along the lines of safety, we have our basic human needs. And we started addressing these things as nurses very early. And we look at them from as we start assessing our patients. Our patient have low oxygen levels? Have they just been exposed to carbon monoxide? How's their nutrition? Do they have access to proper storage and refrigeration for their food? Has it been safely prepared? And think about this in where they're getting care, but also at home or the place that they're living. If they come to you already struggling with access because they don't have proper resources. We mentioned a fever before. Was this somebody who has a low core temp because it is the middle of winter in Colorado and they are somebody who is homeless and they've been outside and now their core temp is 95. They haven't eaten in 4 days. So what kind of basic human needs are we dealing with? Do they have it or not? For safety, thinking about the nutrition aspect of it, it's pretty shocking to me that even with the types of refrigeration and safety protocols and the FDA regulations, that we still have 5,000 people a year approximately die from a foodborne illness in the United States. That number is way too high. 5,000 people from a foodborne illness. So think E. coli, salmonella, like one 5,000 too many bad picnics out there, right? But it's also including like hepatitis A. How is that spread? Do you remember? So that's a fecal oral spread, which means somebody didn't wash their hands after going to the bathroom. You look at other conditions, physical hazards, poisonings have become the #1 cause of accidental deaths for all ages. Poisonings have become the #1 cause of accidental deaths for all ages. Motor vehicle accidents, yes.
I was just gonna say, I think poisoning is interesting, and at the hospital, we're seeing a lot of, like, intoxication of like Benadryl and just overdosing on Benadryl or Tylenol, but accidentally taking the Tylenol, accidentally taking the Benadryl, and them not being considered a suicidal medication. Just
Well, and medication overdoses count as poisonings if they were accidental.
yeah,
So, that it does make our poisonings category, it does skew it a little bit because it does not fall, then they don't fall into these categories of, oh, well, this is a mental health crisis, it was a accidental. Well, they don't even call it overdose, it's accidental poisoning. Well, and think about, so if you have somebody who maybe an older adult has their medications mixed up and they don't remember if they took their blood pressure medication that morning and then they take it again and they come in for low blood pressure, that can count as a poisoning because they took multiple doses of their own medication. So, and I cannot count the number of older adults that I took care of that had taken, well, I think I ended up taking my blood pressure med like 4 times today because I couldn't remember if I took it and I wanted to make sure that I took it. And you're like, maybe you should have taken your blood pressure before you took it the third or possibly fourth time that you took it. And so lots of education. Motor vehicle accidents, while cars are getting safer, they're also getting lighter. When I learned how to drive, I learned how to drive in like a 1982 Buick station wagon, a boat that could withstand anything. And now cars are like tiny and lightweight and could just fly. And they have lots of airbags, which is great. But man, they are dangerous. Falls. Falls of all ages, not great. You bounce when you're a child, but not when you're older. So our nurse's role is a ton of education. If you have the older adults, we're talking about reducing the risks of falls in the home, how we can help them with cleaning those areas up, ensuring proper lighting, motor vehicle accidents. We're talking about reducing harm there, using seatbelts, not texting and driving, those kinds of things. Potential hazards. These can end up being in the home or the healthcare facility. And so we are acting as that patient advocate by ensuring that patient is safe. We want to make sure they have good lighting. Now, whenever somebody comes into the hospital, they are not going to get rest. We hope that they can rest because rest is necessary for health. But think about all the things that we do to them. We're waking them up to take vitals. We're waking them up to get labs. There's noise in the hallway as new patients are being admitted. They are not getting sleep. And if they are somebody who's used to sleeping with it dark in their bedroom, there's a good chance it's not going to be dark in their hospital room. Whether there's a light on under the bed or a light on in the bathroom or the light on in the hallway, there should be some kind of lighting where if they need to get up to go to the bathroom, they can find their way there safely. Because the last thing we need is for them to be disoriented in the room. Even the person who is awake, alert, and oriented can still get disoriented in a place they are not. Want to make sure that the obstacles that are there are away from them to avoid any potential tripping. And this is where education for the patient comes in as well. Bathroom hazards, they're big. Falls, slip and falls in the bathroom, as well as burns from hot water, can be a big problem for our very young and very old, but really anybody. And then when it comes to security, we want both smoke detectors and carbon monoxide detectors for the safety of our patients. For the transmission of pathogens, the number one prevention is going to be aseptic practice, which is going to be our good old fashioned hand washing. And then number two is going to be immunization. So that's going to be particularly for us helping our patients. And what is some routine stuff that we ensure that we're immunized for going into practices versus? You get every year. Flu, absolutely. Then the other big one is going to be hepatitis B and pertussis. So they'll check in, make sure that you are immune to pertussis. Is that can wane as you age, like the MMR. Now we do get concerned with terrorism, particularly bioterrorism. Hospitals have in place how to deal with terrorism, and they should have a plan in place how to deal with the attack. We see attacks on, was that Epic? Kind of a meta attack that got attacked and held hostage, held for ransom for medical records, which I don't know why they would want to hold medical records for ransom. There's probably so much better, if you're gonna hack into something, better things to hold for ransom, but, so they have those types of plans in place, but also there's bioterrorism like anthrax, this is ricin, that little, cute little flowery bean looking thing with ricin. It was after 9/11 that we started seeing anthrax come out. There was 5 people that were killed with that. There's a lot of other potentials for bioterrorism that hospitals are ready to deal with or should be ready to deal with. It depends on their location though, whether or not they would have antidotes for certain ones, or they would be like in contact with a larger facility. So say, a tiny clinic in Lamar is not necessarily gonna have antidotes for bioterrorism attack, but they would be in contact with the hospital in Denver ready for that. Now, when we look at factors influencing patient safety, the developmental level of the patient is going to be important. Think about if you are caring for a 2-year-old versus a 22-year-old. So if you have a 2-year-old that's in your care, there's a chance that they may be still appropriate for a crib as opposed to a bed. You want mom or dad to stay with them versus your 22-year-old who they're at their correct developmental stage. They're going to be able to follow directions. They're going to be able to answer questions, participate in their care. We're going to talk to them about lifestyle choices, how they got there, taking any medications, right? Versus that 2-year-old, we're relying on mom and dad to give us all that information. And we're relying on mom and dad to help be part of that safety team to ensure that kid's not jumping on the bed and jumping out of the bed. See how that developmental level is a really important aspect of that. Now, am I going to be talking to that 2-year-old about whether or not they're smoking or drinking? Probably not. But I am going to talk to mom and dad about, is there smoking or drinking in the home? And does that kiddo have access to, I don't know, maybe pulling a TV down on themselves if it is on a tray or something instead of being on a good solid surface. Right? So we talk about safety issues that are appropriate to that developmental stage as well as that cognitive stage. And then we talk to them about what are those common safety precautions that would be appropriate for that age. That 22-year-old, they're a male, they are likely to be more inclined to make some risky decisions. Do they drive a motorcycle? If they do they wear a helmet? All the padding. If they are going to school, if they do not have a single sexual partner, are they using precautions? What kind of things are they doing? Does mom and dad have the 2-year-old in daycare? Their immunization's up to date. They have any siblings? The siblings for the school. They live on a busy street. It's the kiddo play at the park. Like those kinds of things. You want to have those conversations. For our infant, toddler, and preschooler, general traumatic injuries are the leading cause of death in children over the age of 1. And a lot of it has to do with normal growth and development. Their bodies outgrow, like they're constantly trying to keep up with how their bodies are growing. So when you think of that you've had kids, you think of that big old head and how they're like running their head is too far forward for their run and then they just tumble and, that's how I think about infant, toddler, and preschoolers, like that's constantly what they're doing. They're just one millisecond away from an injury at all times. You live in this constant state of fear of what are they gonna do next? It's really quite terrifying. Then you get to school age children and they start adding in the things that they can ride. And not everybody believes in helmets and shoulder pads and elbow pads and all of that. Sport safely. We have younger and younger kids engaging in like contact sports. We should not be knocking their brains around like that. Helmets are very important. And then traffic accidents are added to this group. Our adolescents are risk takers. Peers have a much stronger influence than mom and dad at this point. They're working really hard to develop their sense of identity. So mom and dad, while they're still there, we're adding in, instead of the bicycle, now we're getting in a car. There's texting and driving. I mean, it's, yeah. Our adults, what kind of lifestyle habits do they have? Drinking, smoking, stress levels. What kind of associated signs and symptoms do they have with stress levels? They're more prone to infections. They have GI disorders like nausea, and having any bleeding disorders, headaches. They drink more when they're stressed more. They using any recreational assistance, like, well, if you ask if they use any illicit drugs in Colorado, and they say no, you should also ask to use any recreational marijuana, because marijuana is legalized in Colorado, people often do not equate illicit drugs with marijuana in Colorado, so make sure you ask people. And then for our older adults, falls, and then accidents, like burns and car accidents. And then make sure you're asking your older adult about drugs, alcohol, and marijuana. This is our baby boomers. They're token up, I'm telling you. Don't be surprised when they're like, yeah, I smoke every day. Unintentional poisoning is the #1 cause of death, of accidental death in all age groups. Seems like that might be something to know for the exam, since that's like the third time I've said it. MBAs are no longer the leading cause. So how do we prevent that? A lot of education, drug education and prevention. So this is talking with patients and letting them know, what does unintentional poisoning look like? It was mentioned before that people are coming in accidentally overdosing on Benadryl and Tylenol. I don't know if you guys have noticed, but now on the top of medication lids, there's a warning that says this medication contains acetaminophen. Because too much Tylenol is very bad for you. And so many medications contain acetaminophen as a mix of other medications. And so more and more medications that have them as a compounded drug, so things like Excedrin is a combination of acetaminophen, aspirin, and caffeine, have that warning label on the top saying, hey, make sure you know that you're taking this. Um, other precautions, use caution as a pedestrian. You guys live in the Springs, you may know that people have been hit and killed outside of Colorado College, in front of, Palmer High School, as well as, what's the other one? The other high school is just like last year, hit and killed. Which one? Can't remember. Doherty, that's the other high school. Use the seatbelts as they're supposed to, and then proper age-dependent restraints for children. For falls, depending on your facility, it will look a little bit different for what the fall risk looks like for your patients. Most everybody has at least a yellow fall wristband. It's a cute little yellow grippy socks, and usually a yellow gown that goes with it. But the sign that goes on the door may look a little bit different. One facility in the Springs actually uses like a falling leaf. Kind of cute. At Anschutz, they have these cute little signs that have different dogs and cats on them to educate the patient and family about how to not fall, which are really cute. First time we were there, it had a little corgi on it. I was super excited. Then we got a cat the next time, and I was like, "Can we have the other room? I don't want a cat." But yeah, so it'll depend on where you work, what your fall risk looks like, but it's usually a nice little bundle of Please Don't Fall. For equipment related accidents, we do not want them to happen. So if you have an equipment malfunction, you do want to make sure that you are tagging that and putting that equipment out of service. Restraints, you guys went over in detail about restraints in the lab. So make sure you recall that information. That again, that's testable material. I think we go into that a little bit more. For the Joint Commission, these are the, yes.
To the other side of class, the side rails, so like the fall risk, because I know you can't have all of them up.
Yes.
What is like the best one to count?
So it's gonna depend on, I think I have more slides on side rails. So side rails are actually more harmful to have them all up because a fall risk patient, especially one that's confused, has that potential to try to climb over or slide between. So if you have, now we have the 4 as opposed to just 2 solid ones. So having a full side up is fine, like 2 on one side and then like the top one on the other side and just leaving 1 down. That's okay. That's not considered restraints. If a patient requests to have all the sides up for their comfort, you can have it all up and then you document. Patient requests all sides up for their comfort and safety. Done. Patient request, but that is fine. Yeah. Yes.
So can you put up all 3 and then have the tray table go over in that 4th spot, or is that considered?
Well, I mean, technically you're putting it like not over that 4th because it's like there's still, the patient can still get out. They can just move that. That doesn't take much to move. So it's not, it is because it's movable, it's not restraining them. So yeah. Okay, Joint Commission. This is a live link to go to the Joint Commission Hospital Patient Safety Goals. If you would really like to read more about what their goals are, but here are some never events that they say should never ever happen. Some examples, there's 28 of them. These should never happen, and if they do happen, Medicare will not pay. Foreign objects left in a patient, that should never happen. Air embolisms, and administering the wrong type of blood. These are just some examples. Wrong site surgeries fall into this. Which you'd be surprised. They do still happen, which is absolutely shocking to me. But prevention is gonna be the key. So we want to, how do we make sure that things don't happen? So when we're looking at falls, a fall risk assessment is one of the things that we need to do to, depending on your facility, which fall risk scale you use. Increase the frequency of rounding on your patient, and that is a team effort. That is not just put on the nurse. It's not just put on the CNA or the patient care tech. We want to make sure we orient the patient to where they are and what we're doing. We want to place disoriented patients as close to the nurse's station as possible. That means we have more eyes and ears on them, and we can figure out what's going on. Increase the toileting of the patient. That really helps for increasing that frequency of rounding. Patients are getting out of bed because they need to go to the bathroom. That is an inherent thing that we try to do, is we're trying to get up to go pee. So that's one of the reasons why they're wanting to get up. Place the call light within reach. I do not trust nurses who deliberately put the call light out of reach, and it happens. You will see it. And it makes me really mad. Because if that patient has been on the call light repeatedly, there's a reason why they've been on that call light. Don't put the call light out of reach because you're annoyed by the patient. That only increases the risk for something bad to happen. Keep the beds in low and locked position. That should be a given regardless of if that patient is fall risk or not. And then if you can, encourage a family member to stay, but they are not responsible for that patient. It's great if they can be there, but if that patient tries to get out of bed, it's not their responsibility to keep that patient in bed. You know, you can tell them, if you're here and you're trying to get out of bed, please push the call light and we'll come in. But it's not their responsibility. For further safety, we want to assess the patient. It's patient-centered. What is happening with that patient that makes them at higher risk for something happening to them? Are they confused? Do they have some sort of medical thing that's making that worse? What does the patient's home environment look like? Is it drastically different than what we're doing here? What are those assessment questions that can help us understand what's happening with that? So is there activity and exercise? Is it tolerable? Like, can they get up and ambulate to the bathroom? Can they make themselves stuff for their meals? Or are they completely dependent on friends and family? Those kinds of things are going to help you to know, is this better or worse than they normally are at home? What kind of medications are they taking? As you guys are getting farther into pharmacology, those medications are going to give you lots and lots of hints. You're like, oh, And have they been taking the medications the way they're supposed to? Just because a patient's on a medication doesn't mean they've been taking it the way they're supposed to. And if they tell you, yeah, no, that's not how I take the medication, don't just document non-compliance, figure out why. Figure out why, because that's also going to give you lots and lots of information. Do they have a history of falls? If they came into you because they fell, that answers your question, but why did they fall? Did they fall down because they tripped over their cute little dog or iguana? Or did they fall down because they got dizzy and fell down? Those are two very different reasons, right? I mean, I trip over my dog all the time. She's constantly like in and out of my feet because she's herding me around depending on where she wants me to be. But if I walked out of here and got dizzy and fell over, my cute little dog's not here with me. Probably need to get that looked at. What are those risks in the immediate environment? Are we creating those risks for falls? Well, yeah, if I've got that patient all tangled up in sheets and stuff. Minimize the risk for medication errors. We're gonna talk about that a ton when we start doing meds. And then we talked about disaster preparedness more. All right, you do want to know normal vital signs for normal adult ranges, which you guys should have already started as well in health assessment, health assessment. Right, these should all look normal to you or look familiar. So, falls. We're gonna go back to falls because it's so important. It is the most common incident report. There's lots of different things that impact that. Poor vision, cognitive impairment, generalized weakness or dizziness, difficulty with walking, drowsiness from medications, alcohol or substance abuse. And then when we look at the most commonly used fall risk assessment, we use the Morse fall scale, which is this. And the fall risk is based on factors, and it's a total, it's kind of more than the total scale. It gives us an idea and which target interventions need to be put into place. And you can, one thing I want you guys to remember is that we do a fall risk assessment on admission. And with any change in patient status, this is not just a one and done. So patient gets admitted, let's say they came in for fall. They have no other secondary diagnosis. They don't use any ambulatory aid. And when they're first admitted, they have no IV. Their gait is normal and their mental status knows their own limits. So at admission, they're only at 25. But by the time we're done with them, I don't know, 8 hours later, they now have a secondary diagnosis of TIA. He still is no ambulatory aid, but he has an IV. I'm going to make him weak, and he still knows his own limits. Well, now he's already increased his fall risk, right? So anytime that patient's status has changed, redo your fall risk scale. That will save you, especially if you implement the fall risk like bundles that go with the score. Because first of all, if your patient has a history of falling, they're already a moderate risk. Once you get high risk, they're above and beyond. But don't take a chance at your patient falling and you not being covered because you didn't have those fall risk bundles in place. Yes.
Did you say if the patient has a history or if they come in for a fall that they're
Number
moderate?
one. So I think the one for it was written a little bit differently for St. Francis. It was on fall within the last 6 months. I don't know if it's the same. Is it the same for where you work for the history of falls? Is there a time frame on it?
Yeah.
3 months?
Don't make,
Yeah, so it'll depend on your facilities to when the time frame is. When I worked at the surgery center, ours was a history of falling within the last 6 months. So it just depends. Like I worked at an orthopedic surgery center, so every single one of our, not every, most of our patients had some sort of history of falling if they were a lower extremity surgery. Almost all of them were using some sort of crutches, cane, or walker because they were coming in for a lower extremity surgery. You know, they had some sort of impaired gait because they were usually non-weight bearing, you know, kind of thing. So almost all of our patients were fall risk when they came in. So, you know, knowing those is, or they were a fall risk before they left. because we just operated on them. And then we have lots of different priorities depending on what's going on with your patient. So risk for injury, risk for poisoning, risk for trauma, risk for falls. All depending on what you've gathered, for your nursing assessment. And then our outcomes, we're looking at preventing and minimizing threats. What are you looking at that is measurable and realistic? How can you include your patient as an active participant? Making sure that you're utilizing teamwork and collaboration. And then keep in mind, these are all things where you're going to be adding to your concept map as you're creating them, starting tomorrow. When we are implementing prevention, these are all different types of prevention across what we're working on. Falls we push and we talk about a lot because it's such a big concern within healthcare. There's also the risk for fires and electrical hazards. Fires within the OR is a huge concern. We want to avoid using restraints whenever possible. Mercury spills, there's still medical equipment that uses mercury. And then violence. Not only do we talk about like physical violence between a patient and like medical staff, but also lateral violence, like bullying. Want to create an environment in which that's not tolerated. Some prevention of falls, we want to make sure that the wheels are locked on the bed and wheelchairs. Keep in mind, if the only way that your patient can get around is in a wheelchair, we do not lock the wheelchair if that's how they're locomoting. If you are using the wheelchair, you have blocked the wheels, the patient is getting up and transferring, that is different. But if your patient, like long-term care facility, you cannot go park your patient somewhere and lock the wheels, as that is the only way that they are able to move around. Otherwise, that is considered restraints. It's non-skid slippers, make sure we have adequate lighting, tons of family and patient education. Identify medications that increase the risk of falling. As you guys are starting deeper and deeper into pharmacology, that's one thing I really want you guys to pay attention to. What medications make your patient hypotensive? What medications increase the risk for dizziness? Think about those things as risk factors for falling, not just as a side effect. Think about what does that mean in terms of how would that present? So yeah, I can say that hypotension is a side effect, but how would that present to me as I'm dealing with the patient? When my patient tell me they're nauseous, when they tell me they're lightheaded, when they tell me that they're dizzy when they stand up, what does that look like? All right, here's our side rails. Side rails lead to serious falls and injuries. Older beds have the full length side rails. If you use both side rails, they are considered a restraint and are more harm than good because patients will try to climb over them. They will climb down the end of the bed. I have seen beds like full on tip. It's very scary when you have a bed halfway in the air, patient halfway to the ground. It's terrifying. The half or quarter length beds or side rails, the upper side rails can be up and used to help aid and help them get up and down. And you can even have the third, like lower leg one up. You have a total of 3 of the 4 up, and it would not be considered restraints. You can put that 4th one up if the patient requests it, so long as you document that the patient has requested that for them to feel safe. and ensure that that patient is alert and oriented and able to call with the call light that's there. And they're able to verbalize, they will call, they need to get up, they cannot climb over the sidewalks. Restraints. This is any device that restricts a patient's voluntary movement or access to the body that cannot easily be removed by the patient. Never use a double knot. We want to avoid restraints whenever possible, so you use all other things before we put restraints.
First side rails, is there a way that the patient can like move them down like inside of the bed, or can you do it from like outside of the bed?
It's really, you can kind of put them up yourself, but because of the way that kind of have to reach over and get the side, you'd have to have really long woopy arms to finish it that.
I don't know if there was like a button. on the
No.
remote to give you.
No, you can pull them up yourself, but you really can't. Yeah. No, you'd have to have like, you'd have to be very, very flexible.
Question about side rails.
Yes.
What if a patient's family, like when you're not in the room, adjust the side rail? Do you have to adjust them back?
So I would, if you keep going in and they keep being up, I would just have a conversation with them and say, hey, is this at a patient's request or did you? And find out like what the deal is with that. And they're like, oh, it's just safer, you know, explain to them that we usually leave one down. So if they wanted to get up or swing their legs to the side, then they could. And then dog. Because you don't want.
That goes for any equipment. A kid could be in there and stuff.
Yeah. Yeah, so my absolute favorite question in nursing is why. Now, obviously, we can't ask our patients why because that puts them on the defensive. But we can always be like, why? Why did they do that? Right? In our heads, go, why are they doing that? So then go and be inquisitive. Instead of judgmental, let's be inquisitive and say, hey, so tell me what's going on here. Are you more comfortable with the side rails up? You know, would you, or, you know, what's happening? Tell me what's going on. Because once you've had that conversation, you can go in and truthfully document that you have educated the patient and family on the safety of side rails, and in spite of education, insist on putting up all 4 side rails. And, you know, and so then you've done the education and you follow through and, yeah. So. Okay, restraints. They must have an order. It must be renewed. How often? Every 24 hours. You must remove the restraints every 2 hours. To do what? What are we doing every 2 hours? Checking the skin, doing some range of motion situations, repositioning if necessary, right? This all should sound familiar from lab. Does it? What kind of knot do we use? Slip knot. And where do we tie it to? Yeah, not the side rails. Yes, absolutely. So we have mechanical devices, which we count the side rails as that. We also have material, which can be the soft, which are like those. We also have hard leather restraints, which are when your patient is absolutely psychotic and trying to kill you. And then we have chemical restraints, which can be sedative or other medications that are used that are given by injection. Oh, there's the hard leather restraints. We also will use restraints in the sense of the patient is not trying to harm themselves or harm you, but they're trying to remove things from, like if they're in ICU and they are confused enough, or we're not trying to sedate them so much that they stop what they're doing, but we don't want them to pull out their IV or their NSG. And so we do like very lightly restrain them. So it's softer restraints. Vest restraints keeps them into a chair or in a bed. The Joint Commission has a say in this as well. All healthcare facilities must comply with agency and state laws. Physicians must renew that order every 24 hours. Restraints must have supervision, monitoring, and documentation. So that 2-hour removal, repositioning, all that has to be done. And we have to reassess whether or not that patient can have those restraints removed. Are they, if they were somebody who was like combative, are they less combative? Are they agreeable to be able to come out of that restraint now? Or not. The Joint Commission and CMS dictate that it must be medically ordered. It cannot just be a, oh yeah, go ahead, put them in restraints, which is really a good idea. We must have tried other interventions first. It cannot be straight to restraints. So we have to have had verbal encounters, we have to have had tried better alarms, we have to have tried like other things first. And know that restraints are an absolute safety hazard. They are not something that we should do with just willy-nilly. Bed alarms or chair alarms are a good alternative. However, keep in mind that we get alarm fatigue. We become desensitized to alarm alerts because it is there. Things are constantly going off. We hear about 942 alarms each day, which is one alarm every 90 seconds, and about 90% are unanswered. So think about all the different alarms that are going off in a hospital setting. So that's everything from IVs to tele to pulse ox to, and going into a room, those of you guys who already work in healthcare, going into a room, taking a set of vitals. How many beeps, buzzes, stations do you hear just doing that? 25 right there. Right? So think about ways you can prevent alarm fatigue. Somebody have a question? That's fine.
One more question.
Yes.
So is it considered a restraint, the gloves that you put over to keep them from?
Are considered a restraint. I believe, I think, so yeah, they're considered a restraint.
They just changed that recently
Did they?
to now it is restraint.
Oh, yeah.
You have to have an order, yeah.
Yeah. So they have to have an order, and it's medically ordered because we're wanting them to not pull out their IVs and tubes and whatnot. So things that, so if you have like a confused elderly person, sometimes simply putting a washcloth in their hand can distract them from trying to pull something out. Because they want something to like fold and pick at. I had an older gal who she just needed to like be doing things, and her daughter said, just if you have washcloths, just ask her to fold the washcloths. And I brought in 4 washcloths, and she literally folded and refolded those washcloths for 3 hours. And it was enough to distract her. She stopped taking the oxygen off. She stopped pulling at her IV, and I covered it so she couldn't see it. And she just sat there folding and refolding these washcloths. So we can be creative and not have to restrain our patients. We just sometimes have to think outside the box. the.
On the Old Western channel for a lot of,
What's that?
put on the Old Western channel for a lot
Oh,
of.
there you go, the Old Western Channel. Okay, so bed alarms, the other alarms that happen, infusion pumps fail, wheelchairs and beds, not locked during the transfer of patients. So we want to make sure that we have no clutter in the rooms this is an example of a repair order. If a bed or any equipment fails, we want to make sure that we label and send for the repair. And that is taken out of service. We do not use any equipment that is broken. Fires and electrical hazards, the code red, that is the nationwide understanding, that is code red for fire. And the action is to rescue, activate, confine, and extinguish. These are just different types of fire extinguishers. That's another concept, obviously, for tomorrow. Hazards to healthcare workers, back injuries. Nursing has one of the highest rates of back injuries of all professions. 52% of nurses complain of chronic back pain. Fetal sick injuries. Increased risk for diseases such as Hep C and HIV. Honestly, I'm more scared of C. diff. Because I'm very careful with my needles, but worry about C. diff living anywhere. Radiation injury. Ionizing radiation is used in operating rooms, CT scans, and other diagnostic studies. We're exposed to it all the time. And then workplace violence. Like I said, it's more than just patient to nurse, but also see lateral violence. Prevention of hazards for body fluids. Utilize universal precautions as well as the precautions that are necessary for what you're dealing with. Sharps, put them away. The proper disposal is going to be really important. If you work in an area that has increased radiation exposure, make sure that you are following those guidelines. And then environmental awareness of personal safety. That is just knowing your surroundings, being aware of your surroundings, watching that the patient is becoming, is escalating in their behavior. And then for bioterrorism attacks, ensure that you are aware of the emergency management plan. 4 measurements to prevent back injuries. This was also, like I said, discussed in lab. Proper lifting and body mechanics are necessary. Be realistic with your assessment of your ability. If you are 5'2" and 100 pounds soaking wet, and your patient is 6'9" and 300 pounds, you are not safely going to be able to lift that patient. I don't care what body mechanics you use. You are not going to be able to scooch that patient up in bed by yourself. Right? Be realistic. Use assistive devices and help from others. Ask, please. Take care of your body. Elevate that bed. Don't bend over. That's anytime. Sit down, pull a chair up, talk to your patients. Use your legs, not your back. Don't be all hunched over like this. Your back will thank you later. Incident reports. These are a formal record of an unusual occurrence. So think about falls, medication errors, needle sticks, all of the directions for your facility. They're tracked for quality improvement. They usually are filled out by the person who was part of that. Make sure that you use objective terms, not I did, or I felt like this was a big mistake because of. Just say, this is what happened when this went wrong. All right, take home toxins. Hazardous toxins transported from workplace to the home. So avoid skin to skin contact. We also have transmissions that have been inhaled. But you also get it all over your stuff, all over your clothes and your shoes. Lots of people have their work shoes, and they leave their work shoes in their workplace because you walk all over dirty floors and they're gross. Poisonings, same thing that we've been talking about. Prevention, lock stuff up, especially if you have kiddos. Keep poison control number close by. And then the treatment is going to depend on the poison that was ingested. For fires, there's cooking fires, smoke inhalation, home heating equipment. We want smoke alarms wherever possible. No candles left unattended. Lots of people are going to those like candle melter things instead that are electrical and turn off instead of having actual lit fires. Care with electrical cords. Don't have a bunch of things on electrical cords or like extension cords. For scalds and burns, make sure you're turning down the hot water on the hot water heater. Guardrails on fireplaces, turn pot handles in on stoves. Wear sunscreen and be careful when cooking food in the microwave. Carbon monoxide poisoning. Don't cook in a fireplace. Weirdly, I've had a couple patients that I've had come into the ER with that as a source of carbon monoxide poisoning, was actually cooking food on a fireplace. Treatment is 100% humidified oxygen. Falls, we have lots and lots of falls that we can help with prevention. And we go into lots of detail in healthy aging. Non-skid shoes, tidy clothes, proper lighting, grab bars, no scatter ropes. Firearm prevention. Lock it up. Firearm education should be for everybody who's in the home where there's a firearm. I don't care how old that kiddo is. Once they are old enough to find that gun, they should have firearm education. Keep ammunition separate from that firearm. For choking hazards, figuring out the size of what can choke a kiddo needs to be paid attention to. I saw they took a toilet paper roll and anything that fit through that toilet paper roll was large enough to choke or small enough to choke a kid, and that was not allowed in their home. So that was a good way to do that. Barriers to pool, learn the Heimlich maneuver, all very good information. Motor vehicle accidents, failure to use seatbelts, use of alcohol, distracted driving, and pedestrian accidents. Be a cautious pedestrian, use designated seatbelts and proper age restraints. For foodborne illness, food poisoning, proper storage, cleaning, and cooking of foods. Use clean cooking surfaces. And then for vector-borne, avoid standing water, use insect repellents, protect skin skin that can contact with insects, and wipe out any breeding areas. Then we have lots of different ways that we can know what is happening. If you have private wells, have your water tested and ensure that there's no access to sanitation. For weather safety, ensure that you are not out during electrical storms. Death from lightning strikes is one of the most common cause of weather-related fatalities. And yes, I've heard way too many stories. Lightning does strike people twice. Way too many stories. So prevention during a storm, lowest spot possible in a large building, stay away from water, and no use of metal objects. Food for thought for next week. Why is caring for the skin such an important part of the community? Don't forget, Friday is your exam, 1:30. There will be no lecture afterward. I'll post a video for you guys to watch. Dr. Persons is going to come and give that to you guys. For tomorrow, your schedule of who's testing when has been posted. We will everybody will meet in 113, get some instructions, and then we'll start testing after that. We'll be in 112 and use those beds, and then there's gonna be like partitions between each of the beds. So you can like pretend that you're in a separate room and say, hey, I'm checking the orders. You would do that little motion, I'm checking the orders, and then I'm gonna knock, knock, knock. I'm gonna provide for privacy. Wash my hands. Hi, my name is Heather. I'm gonna be your nurse today. That makes sense? So we're kind of close quarters, but there'll be partitions. It'll just be you and your faculty member. Anything that you need help with, need an extra hand or anything, then your faculty member will be that person who is your extra hand. Yes.
These exams are on Casper, right?
No, the exam for Friday is on ExamSoft. Oh. So it's not ready to be downloaded yet. Yes.
For our competency, will all the supplies be there, or do we have to use the NG2 that we have in our note?
Bring your NG from your bag and your sheet.
Where's this?
It will open tomorrow.
Where is this schedule?
It's in the regular 232 class. They posted an announcement today.
2 questions. So we are able to open our YouTube.
Yeah, you can open it.
Okay.
Yeah, just have it like ready to test.
Okay, second question. So we don't have to wear gloves when measuring.
No.
Oh, why?
Why?
Because isn't going in,
Well, you're measuring it.
I know, but we're touching it. There can be. I mean, I know like, because I know it says, of course, we perform hand hygiene and then we gather necessary equipment and symptoms. Right? It said, and they were touching the side rails or touching their skin. So like, wouldn't that just like, I guess, like we had 30 and then we're touching the NGs.
What are you doing to your hands between now and then?
Well, I mean, like, we're touching their skin, right? And the skin can have bacteria, or the side rails can have bacteria on it. So I'm just like,
You can wear gloves if you want to. So the idea is that the nasal passage is not like the cleanest of all, and it's going into stomach acid.
okay.
So it's not, it's not the cleanest of all places, so it's, whatever you're doing here is not going to, that would not kill a patient from what you have touched and the couple of things you've touched. Now, I would not go and like then touch it and then, right?
I will say, like, it does become like a common practice the minute you get into a room to put gloves on, but
I mean, yeah. The other thing is that I will measure my patient and then I soak my NG tube in hot water because it makes it really nice and flexible. So if you guys, we don't necessarily go for that in the test stops because we want it firm to go in because it doesn't, if it's floppy going into the mannequins, it won't shove down. But in real life, if your NG tube is softer, your patients love you more. Because then it's not like hard going down the back of their throat. And so if you measure, soak it in really hot water, and you like wrap it around your hand, it makes it like this really nice nicer feeling going down the back of their throat. I didn't learn that in nursing school. I learned that the first time I put it down a real person. From a nurse that had been a nurse probably for 40 years. I had some really excellent old school nurses that I worked with. So, but if we teach you that to do that now, it wouldn't go down the mannequin the same, the firmer into two.
Remember told that we shouldn't put it in hot water because it can like turn back up.
Yeah, Ben actually had.
Yeah, very
experience.
Yeah.
His officer at his clinic.
Instead of having it in, like,
Yeah, so he showed us a picture of how it stood back up. So he said, don't soak it in hot water,
Oh,
warm
man.
water.
Poor guy.
Yeah.
Yes.
So we're not putting the sterile gloves on for a checkup.
No. It's just a quiz. Oh, yeah. No, sterile stuff starts on with holes. I mean,
People.
just what?
So like reading what's on it.
Yeah. Daryl?
So during lab, there were a couple of things on the competency that she said we should cancel out.
Yes.
I checked I still on the one that was brain and brain.
Yes, so you are not going to be aspirating any stomach contents. I think that's still on the checkoff list. So you can cross that out. And we are not injecting any water into the NG. And you're not injecting any air into the NG. What is the way that we check for placement? Yes.
It was talking about inserting 20 centimeters or whatever, and then checking the back of the throat. Are we
Yes.
just doing that at the end of the insertion when we get the number that we're supposed to have it at? Or
No, you should look to see, like, is it where it's supposed to be? You should at least verbalize it if you can't get the mannequin's mouth open enough to see. On a real person, they should be able to open their mouth and you should be able to see the NG in the back. Or coiled in their mouths. Which I have also not happened.
Are you just verbalizing that we're clamping the tube? Or do we have to do that?
She said we
Maybe
just
the tube is not.
You're not clamping the tube, you're attaching it to suction for order. Otherwise, you're ending up with gastric contents all over. Here, yeah. I mean, those contents have to go someplace. Either just putting a cap on it. Yes.
Do we have to verbalize, the, like, us technically, pulling out the gastric fluid, like the color, the odor?
We're not pulling out gastric content. Nope, none of that. I mean, you may get gastric content out as in real life, depending on what's in the patient's stomach, and they just start coming out. I don't want to scare you guys. It may just start coming out. Yeah, other questions? And I'll answer more tomorrow if this isn't like your last chance. Yes.
So again, with that list, can you give an example of how we could do like the, it's in the gold standard of verification?
Oh, you just verbalize that once you're done and you clean everything up, then you would make sure that there's an X-ray in to verify placement. That the order has been, that there is an X-ray order in to verify placement of the NG.
So if we at the top of the list, doesn't really matter, you can move it at the end.
Yeah, you would just want to make sure that at some place you say, in order to verify placement of this NG tube, I want to make sure that there is an order placed for the patient to go for an X-ray. So, yeah. You essentially, we will have like a little canister and a syringe, there'll be a cup and a straw. And I think we also put like a basin and a, oh yeah, the lube will be there and no, those will all be at the bedside. And I think we have like a towel at the bedside. So just bring in your NG. I think that's also at the bedside.
So what is the syringe used for if you're not checking for?
Well, allegedly, it all used to come with us because we were gonna suck things out and push things in. It's still part of our brains. We just, old nurses die hard, okay? Yes.
So I think the last time she was saying she wanted us to wash our hands.
Yes, you can just verbalize You're washing your hands.
Shouldn't go to the same.
No, you don't have to. You just verbalize.
And, so after the testing, what's next?
After the testing tomorrow, then, we have, if you are not testing before and after, you work on your sterile technique quiz. If you need to work on your concept map with your partners, you can do that, work on your fast point, and then we'll have lunch from, I think it's 11 to 11:45, and then we'll start our groups in the afternoon. Yes,
Where do we find this sterile technique?
it will open tomorrow.
Okay.
Anything else? No, usually people are like, we're out of here. Time to go.
Yeah.
So just have something available when you're doing the NG two, just so you have that ready. And you cap it off with extra.
Yeah, you can have it to where it's not turned on, but it's right.
Yeah, okay.
There's things you learn to be fast. Okay. Think of any other questions, I can answer them tomorrow.
So we don't have to bring the whole bag.
No, bring the whole bag because we have Foley, so we start tomorrow. So bring the whole bag, you'll need it. Oh, and I think. Meds too? Oh, yeah, we do start some meds. Oh, that's right. We do start insulin and stuff tomorrow. I'm telling you, this summer goes fast.